morning, everyone. I'm called Clark Joshua. I work with Baylor Foundation Uganda, and I work as a TB HIV specialist. And today we shall be sharing with you how we've been in position to leverage eCBSS data for geospatial mapping of tuberculosis hotspots in eastern Uganda. We know that the NTB strategy tells us that we are supposed to be ending TB by 2035. But also, we also know that in Uganda, we did a TB prevalence survey in 2014, which showed us that we were missing over 40% of the TB, of the estimated TB cases. Similarly, we also know that we had the COVID-19 pandemic, which actually further reduced this gap or further increased this gap. Because of this, the Ugandan ministry developed a community-based finding activity, which they called the CAST Plus. This intervention looks at community awareness, screening, and testing. Biannually, we do a 5-day screening, community screening for TB, leprosy, HIV, malaria, malnutrition, antenatal care for mothers, immunization status, and also the WASH aspects. But we realized that with this activity that we were doing at community level, we were spending $66 in terms of provider cost to identify a single TB patient. And it also produced variable results across the country. Similarly, in 2020, Uganda adopted the electronic case-based surveillance system. And this system was moving away from the paper-based, in a sense that all our data around TB patients was or is being input into an electronic version. And this system provides a standard course of patient-level data about their cohort of treatment and also place of residence. We used this data to develop geospatial maps of hotspots such that we can target our intervention. First, what we did was we cannot utilize data which is not available. So the first thing that we did was in the 178 diagnostic and treatment units that we did have, we were in position to scale up to 93% of the diagnostic and treatment units. Of these, 98%, 158 had EMR, electronic medical records system, had a computer which they could be in position to utilize. So as we can see in the map there, that is the coverage in terms of backlog data. We entered backlog data from 2020 to 2024 by that time. And after we had entered this data, we went ahead to define a hotspot. And this was a village with more than 2 TB patients using data from March 2023 to Feb 2024. We then drew maps, and this helped us to prioritize the CAST intervention. In each of the 16 health regions that we have in the country, at least we have one mobile van, which is it has a mobile digital X-ray, which is embedded into it. So we were in position to, as we can see in that picture, we were in position to prioritize and also show them where to go. But also we were in position to do some bit of door-to-door activity in these hotspots. In the results, we see that in comparison with the September 2022, where we went to all villages, we were in position to spend about $50,000 to get 764 TB patients. While in the March, where we were a bit more pragmatic, but also went to the hotspots, which were mapped, we spent about $5,000 to get 155 patients. So this means that if we had used the intervention, the match intervention, we would have doubled the number of TB patients we got in the September 2022 campaign. This led to a 41% drop in the unit cost. Previously, we used $66 in terms of provider costs to identify one TB patient, but this dropped to 37. And additionally, as we can see the hotspots there, we see that we identified 1,040 malaria cases, 27 new HIV positive clients, 210 malnourished children, 2 leprosy cases, and we were also in position to reach out to 1,765 pregnant and lactating women. The learning is that when we focused on these hotspots, we were in position to increase our precision of our cast intervention. But the limitation is that there is some bit of incomplete data that needs you to leverage and also do a lot of data cleaning. And also there is mismatch between the villages, the village names, because every time in Uganda we get new villages. So there is a bit of a mismatch in the data with the GIS files that we do have. In conclusion, this data enables mapping of hotspots, geospatial mapping of where the TB patients are. It also helps us determine the TB burden. Therefore, we can be in position to guide the resources for TB, for community TB interventions. We would like to thank and acknowledge all that supported this intervention, the Interest Committee for allowing us to present this here, and also Baylor Foundation Uganda. Thank you very much.